Hi, everybody. We are getting ready to kick off. So glad to see so many of you here today in real time and space, and greetings to all of our colleagues that are joining in on the Zoom line. I'm Michelle Decker. I'm a professor here in the department. I'm happy to know many of you. Look forward to meeting those of you that I don't know. And in the WSRH area. So we are really excited about today's speaker. We are really just so excited. This is just a beautiful opportunity to have a jointly sponsored noon seminar with PopFam and with International Health. And I'm very excited to introduce today's speaker. Many of you know Dr. Anju Malhotra has recently joined the School of Public Health as a professor of the practice in IH. Seconded to the global financing facility at the World Bank, which is what we're going to be talking about today. But I think Anju's reputation really just radiates from her in terms of really advancing gender equity through high-level leadership roles at UNICEF, at ICRW, building on her demography training from the University of Michigan, but really carrying the torch on gender equity and making sure that we've got an indicator platform and monitoring and evaluation to really track the progress that's being made in gender equity. Brings as well a big focus on child marriage, although I'm not sure if we're going to get any of that today. I hope that we will. So I don't want to take a ton of time, but I do just want to get everyone's enthusiasm and excitement about really this interface of SRH gender equality and advancing that through a monitoring and evaluation partnership with GFF. And I'm just so delighted. Thank you for spending time with us. And I'm going to turn it over to you for the presentation. Thank you.
Thank you, Michelle, and it's such a pleasure to be here and to see people in person at a meeting. It's such a joy. I am fascinated that it's almost all female audience. And I'm seeing that online as well. And it makes me wonder, I mean, on the one hand, I think it's very exciting to see young women in particular being interested in gender equality and sexual and reproductive health to move it forward. But it is, I think, a little concerning that we don't have more men and boys engaged in that issue, and we should think about doing something about it. So I'm going to maybe start with an introduction to just where we are historically and place my talk in terms of 1994 and 1995, when I was just coming out of grad school. And at that time, there was just this enormous excitement and shared optimism, because one year after another, we had two landmark international events that really highlighted, first in 1994, the Beijing Declaration, the Conference on Women and Gender Equality, where Hillary Clinton said women's rights are human rights, and a whole agenda was laid out for moving forward on gender equality. And the following year, especially in my field, as coming out as a demographer who was just getting gender work started in the field of demography, the ICPD declaration, which shifted the conversation on family planning to sexual and reproductive health and rights. There was just a lot of excitement, and we all thought that we were going to be zooming ahead. And then since then, that journey has been quite uneven, because even just by 2000, it was a shock to find that sexual and reproductive health and rights were not part of the Millennium Development Goals. It was equally interesting that gender equality as a goal was sort of subsumed with the education goal, which really, not that education doesn't have gender inequality, but that's not all that gender inequality is about. And it really, really hurt the cause, because where money went and how programs were done really got diverted. And then we had a conservative government that really clamped down on things like adolescent sexual and reproductive health. Funding for HIV/AIDS was picking up, and there were lots of challenges in dealing with sexuality and reproductive rights related to that. So there was a lot of dismay and concern. And then by 2016, I had the privilege of being at the UN and being part of the development of the SDGs. It's true that we sort of got a gender equality goal now, but it's part of 17 goals, all of which are very ambitious and came at a time when the world has been shifting away from a rights discourse. And in the gender equality goal, it's sort of interesting that only one indicator is really trackable and measurable, and that happens to be the one on child marriage, that we really struggle to get it in there, right? Sexual and reproductive health became part of the health goal of SDG 3, so that was a big win. But still, it is such a large agenda that we are now struggling, ironically enough, to argue that essential health services and primary health care should have a focus on SRHR as a core part of what countries are trying to do. So there's a lack of consensus. There's a lot of pessimism right now, and I don't know, and then even the language, we don't know necessarily what gender means anymore, because it can be identity or it can be inequality, or people are still lost after all these years when we say you need to include gender in your programs, and they're like, what exactly do you want me to do, right? So we're at an interesting point, and I think in some ways, a lot of us working in the development space are finding out what women and men in a lot of poor and disadvantaged situations have known all along, that this is not an easy struggle, and it's not a straightforward one, and there are a lot of ups and downs, and there are no easy wins. So I think for your generation, not everybody's from the younger generation, but many of you are, I think it's both a challenge and an opportunity as you move forward. And so I wanted to place what we are currently doing in this context, because I think it's a very interesting context where we need to shift some of our thinking from what we have been doing. And I think we need to shift strategy for change, in part because we've now spent 40 years trying to do something a certain way, and it hasn't always worked. So there's a lot of, I think, need for reflection and maybe thinking we didn't necessarily do everything right. We thought we were putting out a rights perspective, but it has been challenged, and there has been backlash, and there has been backsliding. So some of the reflection I have been doing with some of the colleagues, I was working at the UN University Institute of Global Health last year as a fellow, is that, okay, we can build on advocacy and commitments, but maybe the movement has focused too much on advocacy and getting commitments. Sometimes it's very easy for world leaders to stand in front of a stage and say, we are committed to doing this. And then that actually isn't just hard to translate, it gives them a pass not to do anything. So harnessing resources and power is maybe the area we need to focus on more. There's been a lot of focus on national laws and policy, but now we're really learning that provincial district level implementation is where we need to focus our energy. National laws sometimes mean nothing in this era of decentralization. Money, resources, people flow in a very different way. A lot of gender equality work in particular, and even SRHR work, I would say especially adolescent sexual and reproductive health work, has been very small scale. And it hasn't gone to scale, and we're talking about millions of people in need of those rights and those efforts. And so we need to shift towards larger scale efforts. The other thing that maybe we need to rethink is that we've really focused on comprehensive approaches. And I can see the reason for that because gender inequality and sexual and reproductive health and rights basically permeate everything. I mean, there aren't too many things that I can say that they don't permeate. But that makes it a really difficult agenda to operationalize. So maybe we need to think about more targeted and catalytic approaches rather than comprehensive ones. And then there's been a lot of focus on norms changing hearts and minds, changing the way people think, changing attitudes, behavioral change, communication. But we often leave systems as they are, the functioning and the mechanics of the machineries of government, the machineries of the private sector, the machineries of universities still function in very gender inequitable ways and in not ways that advance rights. So maybe we need to think about focus more on systems change. So having said that, I wanted to talk to you about the project that we're currently engaged in. It's called MAGE, Monitoring and Action for Gender Inequity. It's a partnership between Hopkins and the Global Financing Facility with funding from the Gates Foundation. And the project tries to do 4 things. There are 4 goals over a 3-year period. One is embedded support to the Global Financing Facility, which is me being housed there. Developing gender and equity resource hub with tools, evidence, and a data dashboard, and building capacity within the GFF Secretariat and country clients on gender equity monitoring and integration into reproductive, maternal, neonatal, child, adolescent health and nutrition programming and reporting, and then trying to make that sustainable. So a lot of that, what I just said, may feel like jargon to you, and you're like, Global Financing Facility, what is that? And what are country clients? And what RMNCHN, long word. It used to be, I think, just RMCH, right? And then people said, wait a minute, neonatal has to be there. And then people said, but adolescent has to be there. And then late nutrition said, wait a minute, you left us out. So then the dash and came in. So let me tell you a little bit about the Global Financing Facility, where I have been now for the last 4 or 5 months. What does it do, why it's important, and why it's an opportune partnership for Hopkins to try some of the newer, more creative thinking reflection that I've just been talking about. So it's a multi-donor trust fund. And what a multi-donor trust fund is, just basically a fund in which different donors pool their money. And so the UN agencies are called multilaterals because donors also give them money and they pool money, but they are established organizations that function with a certain mission and have been established for a long time. But the world has created, in the health field in particular, donor funds that offer particular really disease areas. It started with that focus. This particular one was created in 2015 to focus on women, adolescents, and children's health. So it's a little bit broader than disease areas. It's the last fund created out of the trio of the biggest multi-donor trust funds that are out there. Gavi, if you've heard of that, is the fund that is there to further immunization and vaccination. And the Global Fund is there to improve work on HIV, AIDS, tuberculosis, and malaria. So they are the 3 largest donor health-related funding mechanisms through which grants are given to countries, usually to governments, but not just to governments, but governments are the biggest grant receivers. What's sort of unique about the Global Financing Facility is that unlike Gavi and the Global Fund, which have their own offices in Geneva and have their own sort of infrastructure and so forth, even though they're very closely aligned to UN agencies. So for example, Gavi works essentially through UNICEF and WHO. But the Global Financing Facility is housed at the World Bank, and the short for the World Bank is WBG, World Bank Group, which includes IFC and so forth. And it's mostly focused on largely African countries, a few Asian, and a couple of Latin American countries. What the Global Financing Facility is trying to do is that when the World Bank gives a project loan to a country for health improvement, the Global Financing Facility gives an extra grant to top out that loan so that it can add a focus specifically on maternal, neonatal, and child health and sexual and reproductive health. One of the more important things it does besides that is that it sets up a country platform of stakeholders and especially pushes the government and other donors to not give funds in separate pots. So if Gavi is also going to give money, and the Global Fund is also going to give money, and the Gates Foundation is also going to give money, and USAID is also going to give money, what the Global Financing Facility does is say, okay, wait a minute, let's all sit down together. All of this should go into the government's budget. And then how are we going to spend it on achieving these results as a pooled fund rather than this donor wants this and that donor wants that, right? So it's also a way of what they call alignment. And this country platform, I think, is an innovation of the Global Financing Facility because it has really pushed the decision-making to country stakeholders, not just the government, but to bring civil society, academics, and other experts to the table in designing the priorities that the government's going to move forward. And the other important bit about the Global Financing Facility is because it's focusing on women's, children, and adolescent health, it's focusing much more on primary health care than tertiary and secondary care. So I think one of the things that I had mentioned to you was scale. So we're talking about scale here, like I had not even heard of when I was at UNICEF, right? So moving from a think tank NGO where our annual budget was $15 million when we were thriving, I moved to UNICEF, which had an annual budget of $6 billion, right? That money then is spent in supporting countries to do things, but still grants and support countries would be maybe 20, 30 million. Here we're talking about hundreds of millions of dollars, right? Here we're talking about, I mean, just you look at Afghanistan, that's a total funding of $600 million. Bangladesh, there are two rounds here, one with both of them over half a billion dollars, right? But what's interesting that you can see is that the blue is the money the bank gives as IDA or IBERD loans. So IDA loans are very concessionary loans and IBERD loans are bank standard loans. Concessionary loan means very low interest, right? Then other partners, and then, you know, the black is the other partners. And I can't even tell what other color is the other trust funds, but that would be Gavi and so forth. Only the yellow is the Global Finance Facility. But the Global Finance Facility makes the yellow come together with all these other colors. So we're talking about usually grants or loans between like 100 to $500 million, 100 million to $500 million. So it's huge amounts of money. And in many countries, we're talking about anywhere from 30 to 70% of the government's health budget. So you're talking about huge share of the country's health budget. So the Global Financing Facility had a strategy refresh. It started in 2015, 2020, in part because of COVID, in part because it was maturing. They had a strategy refresh. And I've circled the two areas that are very important from our perspective. They added or really highlighted as part of their strategy, prioritize efforts to advance equity, voice, and gender equality. And the last one, sustain a relentless focus on results, right? Those two strategic directions are important because that is part of the reason why we are partnering with them. What also happened in 2020 and 2021 is that the GFF issued a strategy paper on its SRHR acceleration plan. These are the things that we are going to do to accelerate sexual and reproductive health and rights. And by the way, I should just tell you that they did both of these things, the roadmap on gender equality and the SRHR, because the donors came knocking on their door and said, what are you doing on SRHR? What happened to SRHR? Why are you not doing more on SRHR? And the same on gender equality. So it's a wake-up call for GFF to have to do these things, which is what I think donors should be doing, is if they're going to put money into this pooled fund, then they should be telling them to prioritize these issues. And I won't go into the details of what they promised that they will do, but obviously they've promised an ambitious agenda, and then they have to fulfill it, which is why the MAGE partnership becomes a very important pathway for them to do so. So for us, I think for Hopkins, this is both an opportunity and a challenge. It's an opportunity because we really have an opportunity to influence serious investment on gender equality and results, especially on health systems and financing. And that's something I don't think I emphasized enough early on, is that World Bank is probably the biggest international organization that has a clout for governments to change systems and financing, because the amount of money it's giving is so huge, and financing is the World Bank's job, right? So it can really influence that. Secondly, somehow I find that when you combine gender equality issues with M&E or data, that has more clout in an organization than if you just come in and say, we're going to do gender equality and SRHR. There aren't, I don't know of any other platforms that have this potential for scale, because you're really working with ministries of health, ministries of finance. And we can, I think, advance gender equality and health measures both at the country and the global levels, right? So it's not just that we have global indicators, but we can work with countries to be able to track results. And I think that possibly COVID has also been a wake-up call for systems change. So even though there have been more crises, maybe donors are more motivated to actually take this stuff seriously. That said, this is not an easy thing to do. Why? Because in most multilateral organizations and even donor organizations, gender equality is still a very checkbox exercise. SRHR is often also a checkbox exercise, because like gender, the SRHR world is amorphous and vague. People are not sure beyond family planning, what exactly do you mean, right? There isn't that much gender and measurement expertise at the bank or in countries that you can build on. So we can do what we want, but ultimately people in those organizations and those countries have to do it. And if that expertise isn't there, it's a hard thing to do. Within the field of gender equality, there's enormous variation in frameworks and indicators and measures, and we don't have agreement. So Michelle can attest to this, that she is mapping indicators right now, and we have all kinds of different ideas of what people think is valid. And there are very few indicators that are available to track gender equality and SRHR work at the institutional level, at the systems level. We have a lot of indicators about women and families and men and communities, but we don't have what does it mean for a system to be more gender equitable, right? And there are a lot of data gaps, especially on systems tracking. So what we, in this 4 or 5 months, there's a large team from Hopkins working on this with me. So Michelle is part of that team. There's students, one of her students, Huda, is part of that team. Indira is sitting back there. She's part of the team. And David Peters, Rosemary Moran, we have a fairly substantial team that's working on it, and we've worked together with the GFF colleagues. And I will say this, that the colleagues at the Global Financing Facility have been very welcoming, are giving me space to engage with them to figure out what we are doing. We have come up with sort of 3 themes that we think are really going to be probable priorities, or that we can move forward on in 3 platforms. So let me talk about the themes first. So one theme that's emerging is quality of care. It's an important theme because from a gender equality perspective, disadvantaged women, poor women in particular, women of ethnic minorities, women in rural areas, do not get treated well by the health system, and their concerns are not taken into account. And it's not just in the interactions that they have with the service providers, it's also with things like waiting times. It's like they get there and the medicine that they need or the contraception that they need just is stocked out, or they wanted this contraception, but that's not the option. So now they have to get an IUD inserted, even though what they really wanted was an injection, right? Or there's no water at the facility and they have to give birth at a facility without water. So you're talking about very serious deprivations in the quality of care that women and children receive in a lot of these places. And I think that is emerging as an area that we can really influence when country reforms are going to happen, and really push for improvements in quality of care. The second is financing for healthcare access. So one of the areas that financing can come in is from social protection. So there are cash transfer programs, subsidies, because a lot of poor people cannot pay for healthcare. Governments have social protection programs that give money or vouchers or subsidies or insurance benefits to people so that they can access healthcare. Well, how are women positioned in getting those financial benefits that would help them access healthcare? And then the third really important one is the health workforce. So a lot of health work is done by women. Most of it is unpaid because a lot of it is actually done in families, right? And there's a lot of task shifting right now going on in the health field where there are not enough qualified people at higher levels, so lower level people are being asked to do a lot of work. And that lower level is almost entirely female in most countries. Frontline workers are mostly female. Many of them don't get paid. Many of them get paid on contractual basis. They don't have a career path ahead of them. They get harassed as they travel. Many times they have to pay out of their own pocket to travel for work. I mean, the situations I have seen in countries I've visited, it's appalling. I still remember the day I walked into the UNICEF country office in Ethiopia and met with the country director. and we were talking about child marriage, and he said, Anju, we have it taken care of. We have 100,000 female volunteer army in Ethiopia that can just take care of. These women are just dying to go out there and convince everybody that nobody should have child marriage. And I just sat there and thinking, you're telling me that you want to exploit 100,000 women to go to work for nothing, right? So yeah, but from his perspective, he thought we were going to do a great job. So those are the three areas that we're sort of looking at where we can move things forward. And then the platforms. So one platform is developing indicators and dashboards and frameworks and analysis. Another is doing assessments, gender assessments in countries, doing analytics, implementation research, evaluation research. And the third platform that I see is like developing tools, guidance, and training. And I'm going to start going through this faster to give you some of the examples so we can have a little time for discussion. We have started looking at indicators, and right now it's sort of like just as a initial brainstorming, we have 4 or 5 different spaces going on this, but we're finding that we need to develop health systems related indicators. We need to develop social protection related indicators. We have a lot of social determinants related indicators. Those are the ones you're probably the most familiar with. But then we need sort of health service related indicators that are about experience of care and provision of care in terms of quality. So for example, even the fact that is family planning part of essential health services, we found out in COVID, a lot of countries didn't consider it as part of essential health services, and women were denied family planning access, and rates of contraceptive uptake went down. Access to services that I mentioned, some of those areas, but then utilization related sex differences in utilization, but also sex-specific care by age, especially for adolescents. It's very important. So we're starting to do work in that space. I don't know if you've heard of an initiative called Countdown 2030. It is the sort of tracking mechanism for RMN-CHN progress across the globe, and part of it is housed at Hopkins. So we're working with them to see how we can move things forward. There's another initiative called Track 20, which is there to move forward family planning. We're connecting with them to see how we can leverage what they're doing. We're doing stakeholder analysis of the relevant tools as we're curating on gender equality and SRHR. And then we're figuring out how we're going to do trainings with different countries, GFF liaison officers, the SRHR specialists at the World Bank in different countries, and so forth. So I'm going to tell you about 3 specific things that I'm quite excited about that we're doing. So during COVID, GFF operationalized rapid phone surveys to collect data quickly on what was going on and what was happening with essential health services. And they want to now continue that, because right now we get use DHSs and MICs to get data every 4 or 5 years for a country, which by the time the data come out is too late for the country government and district people to say what happened and did we do things right and what's going on. So the rapid facility surveys are a really good, cheaper way of moving things forward on a more routine basis. Now, countries are supposed to collect more routine data, but a lot of it is very flawed. So we're testing out how much rapid phone surveys can fill that gap. And what we found when we looked at the surveys that they had done was that there were almost no gender considerations in that. So for example, for her rapid household phone surveys, do women even have access to cell phones? Who is the health facility person you spoke with? Was it a supervisor? Was it a male? Was it a female? Did you collect information about things like, were there 2 or 3 contraceptives available when women came to get contraceptive, or were you always stocked out? So things like that we are now integrating into those rapid phone surveys. Again, it's a GFF initiative, and we can help to make it sustainable by bringing in the gender element. A second really great opportunity is in Pakistan. I'll be going there next month. So the World Bank has just funded a massive $300 million health project to advance the Pakistan National Health System plan, and other donors, every donor is there, Gavi and GFF and Gates and USAID and you name it. And it'll be kicking off in 4 provinces. And one thing we've made sure is that family planning and maternal health are core areas of focus, and especially gender barriers in Pakistan. A lot of it has to do with mobility. Women are not mobile, they can't, especially after they give birth. 40 days in the house. So if something happens, how are they supposed to access care, right? They need permission, they don't have money, all kinds of issues. Those things are being well identified in the plan. And then GFF itself is going to lead the monitoring and evaluation. And we are partnering with each province to see if we can embed a results person who we will then train on gender and SRHR and M&E, and working with partners like the Population Council on surveys and rapid cycle, but most importantly, teaching the government how to use the data. So we'll be doing a lot of trainings with the government, with Pop Council on creating dashboards that have gender data in there and that they can use it. Another one that I'm really excited about that we're just starting, and Indira and I have been working with our team on this, is Cote d'Ivoire is another priority country for us. They are going to go into the cycle for the next loan from the bank. And they have been really big in rolling out their health insurance scheme, and they want to focus on getting their insurance scheme out to everybody. But they have a 2-tiered insurance scheme. One is for people who have jobs, and one is people who don't have jobs. Well, women are much less likely to be in the formal sector, which means that they're almost certainly only getting insurance through their husbands if in that first tier. And it's a country where there are a lot of informal marriages, there are a lot of polygamous marriages. What happens to a woman if she's not in a formal marriage? Does she have to have the papers to prove that she can have insurance? If a woman isn't married, and she doesn't have identity papers, can she go get insurance? If she gets insurance, then can she actually use it? Does she know which provider will honor her insurance, right? Does she go to the provider, and does the provider who's going to get paid a standard fee for the service give her the lower rate fee so that he can pocket the rest, right? So all of those specifics are what we want to do as part of the gender assessment of the insurance scheme for modifying going forward. So I'll stop there. I've been talking a long time, so it would be great to get your thoughts and reactions and how to build on what we have at Hopkins to build this partnership and get something really meaningful out of it. Thank you.
Hey, thanks so much for this talk, and wanted to just note how much I appreciate the focus on not just like what, but how. And so I think that's, from a practical perspective, really helpful for us students to understand. I was, I think, struck when I was looking at some of the priorities around sort of the lack of discussion around gender-based violence. And you brought up, for example, the topic of Pakistan, or Pakistan as a country, and Afghanistan were listed as one of the countries that receives a lot of funding. And so I was curious to hear especially thinking about workforce and thinking about family planning and coercion, right, is what will be the focus on, for example, survivor support and on ensuring that, for example, like psychosocial staff, right, that there's also support for staff, just given how difficult that job is and how much burnout there is, and how do we focus on quality of care of that and include that into this process.
Great. Why don't we take a couple of questions and then circle back? Any other questions from people online? Any questions? Yep.
I kind of have a question about loans. So I know that a lot of the loans were given under the assumptions of like a low inflationary environment. And now we have high inflation, high interest rates. And I know there's a little bit of like questions around like country stability and like worries about being able to handle those loans. I'm just wondering if that impacts the work at all and how that's going to be kind of, I don't know if those loans will be adjusted or like what that process will be like and if it places a lot of stress.
Okay, I could answer that. Yep.
I was wondering what the partnerships with the different countries look like. Is it mostly just working with the governments, or is it based on like focus groups with women that are like the people, the citizens of that country, mix of everything? I just want to know how you think of the agenda items.
Great. So let me start with the quality of care question and the health workforce. What I'm finding is that although the health workforce is a core part of what the World Bank Health Team would like to consider and has it on their agenda, it's not very well developed. So, and actually I shouldn't say that. This is one of the challenges, is that there are things that the World Bank is doing, and then there are things that the GFF is doing, right? So GFF is a subunit within, very small subunit within the bank. The bank is doing a lot of things on health workforce, some of which has gender integrated in it. The GFF has not been doing a lot of things on the health workforce other than really just looking at how the health workforce gets funded. Their main focus has been on the financing. So we're at a point where the GFF is being pushed to look at the health workforce in more detail, and that's why I see it as an entry point. When you don't have a preconceived notion, then it's an entry point. The question on Pakistan is that there isn't, in almost any of these countries, there isn't enough of a health workforce. I mean, the shortage of health workforces worldwide, but especially in countries where you're talking about a country that is spending maybe $5 per capita on health, but has a national plan that costs $30 per capita on health, right? So you have only like 1/6 of the budget for all the things that you want to do. And in most cases, most of the money does go to paying the workforce, who don't even get paid on a regular basis. Sometimes, you know, they're 6 months behind and so forth. They still have to pay for supplies and facilities and all these other things, data and all these other things that they need. So there's a lot of motivation to exploit the health workforce, and especially women. In Pakistan, you're right, there has also been coercion in the past because family planning has not moved well in Pakistan at all. The rates of utilization are still low, and part of it has been reliance on the government, which doesn't have the infrastructure and is offering only very limited contraceptive options. But Pakistan has also had this lady health worker program who are part of the civil service, which is actually unusual, who are the sort of contact points for a lot of women. So we're trying to see what reform is possible there in terms of their role. there is actually push to take them off the civil service because people think that that has made them non-effective. It's made them sort of very complacent in their jobs. So that is a question up for consideration. Can we mobilize other safety rights-based approaches to how the interactive staff are trained? But you can only do that in a limited way. I mean, the lower level staff have only so much autonomy in what they do. You can train them all you want, but their incentives, their motivation, their supervision is what what is required. So it is going to be a tough challenge. It is on the table. So we will be talking to the different provinces. I think what we're going to have to try is take the province that's most motivated to make a change and start there. But this is not an easy task to move forward. On the loans, most of the bank loans to very poor countries are IDA loans. So they're very concessional loans. They're very almost no interest rate or very low interest rates. So that's not so much the issue. And in some senses right now, part of the reason that loan is so big is because Pakistan's economy has been doing a nosedive and the bank is trying to prop it up by giving the loan. So yeah, that's not the issue. And what was the last question?
Just how are these agenda items, especially when we were talking about the last country that you're going to roll out in? I'm forgetting Cote
d'Ivoire. Yeah.
I'm sorry.
Yeah.
But it seems like there are a lot of agenda items that you're gearing up for. Is it based on the government's what they want, or is it based on focus groups that you've had with people who live there? Like, where are these agenda, or is it mostly just what the donors want? Where are these like specific goals coming from?
Yeah, so there are two ways that it works. So the direct interaction will be only with organizations, not people, right? So it'll be with the government ministry of finance and the Ministry of Social Protection and the Ministry of Health. It may be with the provincial level people in those ministries and asking them what they want, what they have experienced and so forth, right? It may be looking at data, but part of this whole idea of the country platform is that there will be meetings set up to bring in NGOs who have worked with people in communities, right? Or women's rights organizations or youth organizations, but also academia who have been doing research, right? So it'll be with organizations. But when we say, let's do a gender assessment, what will happen is it'll be commissioned to some organization to run the gender assessment. So it could be Hopkins that'll do it, but preferably it should be an institution in the country that's going to run the assessment. And then they will use data. There'll be a design. So it'll be some data that's already there. They may go do a survey, they may do focus groups, they may go talk to people. So assessments are basically studies that you're commissioning that are done depending on the methodology of the study.
I just want to make sure we get back to Khadijah's question as well.
Yeah, I didn't fully understand Khadijah's question. So will you recap it? Khadijah, what was the most important point of your
Sure, I
question?
think you got part of it. I think one of my questions is around, gender, like how do we incorporate gender-based violence response, right, into what you're doing? And I think like there's a focus on gender equality, there's a focus on family planning, but if you're going to be working on family planning, you're going to end up with cases of GBV, right? And so how do we ensure that there's adequate support?
I see. Yeah, so those are choices we have to make. So right now, the way our thinking is that the bank does not have good capacity on gender-based violence at all. It doesn't have good gender capacity to begin with. So if we're going to do anything from the bank side, it's better, we have to have counterpoints. We can't like I, as one person, can't go and do all this work, right? And you have to have the people in the bank that I would have to mobilize to do it. So which means people in the bank's DC office, and then people in the bank's Cote d'Ivoire or Pakistan office, who will then talk to the people in the bank's possibly provincial office. So it's down the run, right? So it's not off the table yet, but I'm not seeing the bank as the best organization for moving forward a GBV agenda. But we have lots of good partner organizations that are very good at moving forward the GBV agenda. So the way that we're looking at is to bring those organizations to the table who are either already working on it, or, for example, influencing Gates or Gavi or somebody else to fund them, so that that work gets done. And to the extent that GBV is built into the measurement system, we can certainly partner on that, because on that, we, for example, in Pakistan, we will be, the GFF will be the M&E arm, and I will have a say in it, so we can do that. But we have to be, again, strategic, because GBV is a very critical issue, but it's not the bank's forte, so we have to choose. We are choosing instead things like quality of care access and so forth, because that's what this financing is able to do. Yeah.
I've worked pretty closely with lady health workers in Pakistan, and I've seen that they've protested against the government for not getting their salaries or benefits. So I'm curious to know, like, in terms of this project, will it be going through the government or independently, like you mentioned? Since, like, with the government, it's like I'm not sure how, like, I'm curious to know how the GFF would ensure that that the health workers actually get that compensation and everything.
Yeah, so again, we have to remember that GFF is part of the World Bank. So the big thing the bank knows how to do is give out money, right? That's like their number one competency. The number two competency is to link some results to that money. Everything else, it has to be negotiated and partnered and cajoled. So most of the money will go to the government. It'll actually go to the finance ministry, and then the finance ministry will fund mostly the health ministry, but maybe also the social protection ministry. And mind you, this is not the only project. There are many bank projects. So some countries are getting billions of dollars in bank loans. So there's another bank project for Pakistan that's coming up that's just on family planning. And we're looking at that as our second leverage point for doing some of the things we're not going to get done under this project. So, for example, GBV may be a bigger space in that project than it currently is in this project. But some of the money, especially GFF money, can go to NGOs or to partners. But usually there's the way this works, and this is a reason why a lot of things don't happen correctly or as we would wish, is that there's so many pathways. So GFF is not going to give money directly to mostly a Pakistani organization, unless it's like the Population Council, that's also an INGO, right? It will give money to that organization, which will then give money to Pakistani organizations and bring them into the play. And so there's some trickle down of mission as you go further and further down. So this whole issue of their getting paid is actually being built into the government agenda. And in Pakistan, it's at a provincial level. The national government is not going to do this. It's going to be, so it's in four provinces. So the Punjab government will sit down and the bank is very good at saying, how are you managing this money, right? So how much is going to salaries? Why are salaries not getting paid? Can we fix your management system so salaries are paid on time? Part of the reason salaries don't get paid on time and lower level workers suffer because the upper level workers have more clout, right? Is that there isn't money. I mean, it's not, the government just doesn't have money, right? Which is why when we sometimes say, oh, we should have somebody to support this service or support that service, realistically, there isn't money to even support the very basic service, right? And I always think about, for example, adolescent sexual and reproductive health. In so many countries, we keep saying, let's do comprehensive sexuality education in schools. Like you're talking about schools that don't have teachers to teach basic reading and writing, right? Who's going to teach comprehensive sexuality education? Who's going to train the teachers who are going to teach comprehensive sexuality education? You're having like 60–70% of kids in 5th grade or 10th grade coming out without the ability to read or write. So you have to make your choices about which quality element you really want to build in. Right now, the education feels completely focused there, like comprehensive. Yeah, sure. If you want to put it in there, sure. But really, we need to focus on just getting kids to read and write. And that's a gendered issue too, because guess who most of the teachers are, especially at the elementary level. They're females who are also not getting paid because the education department does not have enough money. Right. So we're talking about a machinery that is exploitative of women in many different spaces, and you have to pick and choose which exploitation you can fix at a given time. Yeah.
Oh, thank you so much, Andrew. This is really exciting. And I remember when the GFF was founded, I was super excited. And it's been 7 years now. And as a researcher, I still I'm having a, I still have this hard time to figure out how do I interact, with this whole GFF and GFF affiliated or really initiated agenda, so that just as a sort of RMN, EHN researcher, I'm trying to get an acronym here. We can at least, contribute or maybe actually even influence or advocate for some of the issues. It doesn't have to be sexual and reproductive health. It can be, CAH or other things. So how do we, what's the best strategy to, from the researcher's perspective to interact with that process?
Yeah, it's a very insular space. The GFF does contract out a huge amount of research. But the bank and the GFF is used to having its trusted research partners that it'll go to on a regular basis. So part of what we hope that MAGE will do is it makes Hopkins a trusted research partner. So beyond MAGE, as GFF starts to see, we can do a gender assessment on such and such, we can do a maternal health analysis on such and such, we can do an SRHR indicator development, then we become a trusted partner, and we have, and that's one of the things I'm very much hoping is that colleagues who are very interested in some of these issues will connect with the project. And even if immediately there isn't space for them to do something, there's a good chance that in 6 months there will be, because there'll be another country that you have expertise in and you have partners, and we need really, something really useful. So like out of the blue, this week, CRVS came up as an issue. So civil registration and vital statistics. And what's the gender dimension on civil registration by vital statistics? And I know Michelle Kaufman's gender data team is working on that. And I'd like to connect more with her as we move forward. So there are lots of spaces to make those connections going forward. I will wrap up then. Thank you very much.